I am now delighted to introduce Dr. Tony Goldstone. Dr. Goldstone is the principal investigator and head of the Psychoneuroendocrinology Research Group in the Neuropsychopharmacology Unit, Centre for Psychiatry in the Division of Brain Sciences at Imperial College, based at Hammersmith Hospital in London. Dr. Goldstone attended medical school at both Cambridge and Oxford universities and works clinically as a consultant endocrinologist at Imperial College Healthcare NHS Trust in London. He is a fellow of the Obesity Society. Dr. Goldstone has researched and published widely on neuroendocrine and metabolic abnormalities in Prader-Willi syndrome and early onset morbid obesity, particularly investigating the causes of hyperphagia and obesity. His current experimental medicine research examines body-brain interactions in the regulation of eating and addictive behaviours, with interventional studies including appetitive gut hormone administration and bariatric surgery. Dr. Goldstone runs a specialist adult clinic for genetic obesity, including Prader-Willi syndrome. He has been a member of the scientific committees for PWS expert meetings, the International Hyperphagia Conferences, PWS International Conferences, and has been a member of the Scientific Advisory Board, Foundation for Prader-Willi Research since 2014. Tony, over to you.
Hello and welcome everyone in this slightly unusual way of doing things, but we're all learning as we go along. So thank you very much for the invitation to talk today. This is going to be a talk that's around medical issues in Prader-Willi syndrome. As a bias, as an adult endocrinologist, it really will be focused around the things that I see on a regular basis in my clinic in adults. Some things will be relevant to children to a certain degree, but certainly most of it is related to adults. So I'm going to talk about a sort of selected view of some of the issues we see in PWS, particularly around the hyperphagia and obesity, and talk about what I do, which is by no means necessarily the only way to do things. And one of the issues in PWS is that often the way we manage it is slightly anecdotal, because there isn't always a lot of published data. Although as the years go by, there's more and more. And I'll, throughout the talk, sort of intersperse it with actually the results of an audit that we had from a BSc student a few years ago in our clinic, just to give a perspective to some numbers that we see in our clinic. I think the important thing to realize, of course, in PWS is that it is what we call a multi-system disorder, and it affects, I think, virtually every organ system in the body, and even those that we didn't think it affected, actually we discover when you do look in detail that it does. So although I'm an endocrinologist, my role is often as a sort of a gatekeeper and as a core communicator to basically coordinate the care amongst many other specialists. And although in pediatric care that often works very well, it must be admitted that in adults it isn't quite so clean, not least because often patients are coming from around the country and we need to get them looked after by local clinicians and other medical people locally, and often that can be quite a disparate group of people and often dependent on local resources. This is from a review we did several years ago now. It's a bit old, but I think it's still fairly up to date, of the sort of specialists that are involved. And although endocrinologists are certainly up there, we're certainly not the only people. But by and large, certainly in adulthood, the main care would probably come from an endocrinologist. And of course, one of the issues we have in the UK, at least, is that most adult endocrinologists or obesity physicians are not particularly experienced in Prader-Willi syndrome. But thankfully, that is changing gradually, and we now have several centres around the country who have some sort of multidisciplinary team. But we're still a long way off the sort of setup that exists in many other countries. I think France is probably the best model, where they have 2 national reference centres down in Toulouse and in Paris, and then sort of satellite centres that have a sort of hub and a spoke service. And unfortunately, we're not able to do that sort of service easily in the UK. So although I'm talking mainly from an endocrinology and metabolic obesity side, there are, of course, many other issues that may be relevant that need other specialists. And I think good communication is key. And certainly I would recommend that anybody who's seeing clinicians for their child or one of their clients with PWS is to try and ensure that the specialists look after the person are communicating with all the other specialists. And there's a bugbear of mine that often we don't get much communication, but it's important to try and do that. So this is just the start of the audit a few years ago now by Mithat Ahmed, the student we had at Imperial. And at that stage, we reviewed about 32 patients in our clinic of a broad range of ages. You know, the oldest now is up to 48 years of age. Generally seen on average at about 20 years of age, and oddly, the genetic abnormality, there's a bit of a preponderance of non-deletion people, and that may be a referral bias to my clinic, as I'm sure Tony Goldstone talked about in his last talk. Uniparental disomy is associated with often some more behavioural and psychiatric issues, and it may be that those interfere with the management to some degree, particularly around weight sometimes perhaps, and maybe therefore there's a bias in referral. Also, the prevalence of UPD is getting more as mothers are having children older, as older age is a predisposition to uniparental disomy as the cause. These are the clinical criteria used for diagnosis of Prader-Willi syndrome. Of course, now we have genetic abnormalities that have genetic testing that have superseded the clinical diagnosis, but just to see how those are, the major criteria listed here are pretty universal. Hyperphagia is not seen in 100% of people. There's a few people who don't seem to have developed hyperphagia, but certainly the vast majority do. Pretty well everyone has some degree of hypergonadism, that's those sex hormones, developmental delay, and the classical problems in neonatal period are pretty well everyone. In terms of the minor criteria listed here, you can see the first few are pretty common. Some of the other ones are less common, such as saliva. Skin picking certainly remains quite a common problem, not necessarily everybody in terms of its being severe, but when it is severe, it can certainly be an issue. And some of the other issues are not necessarily causing clinical problems, but are part of the criteria. And then we have a variety of other features that are seen to varying degrees. Temperature dysregulation, I always thought that might be an issue, but actually it's not that common. So that's people who can get cold very easily or get warm very easily. I have one or two patients in whom that's a particular issue, and it causes rather a lot of distress when they come into the hospital for some tests and they measure their temperature and discover it's very low. But you know, that is something that needs to be borne in mind. And this high pain threshold and decreased vomiting is a common problem as well, which can sometimes cause clinical issues. As I said, we had some management guidance now. Terrifyingly, 12 years ago, we published this, but I think actually not a lot has changed, I have to be honest, in our recommendations since then. Focusing first on the management of hyperphagia and obesity, we still are having to rely on the vigorous control of the food environment and regular exercise to reduce the calorie intake. And the time over adolescence and into adulthood is obviously a very difficult time when patients may want to start expressing some autonomy and get out into the world a little bit more. And that obviously can cause some disruption to things when things sometimes have been quite stable in the family home. I'm going to talk a little bit about residential group homes because I think their increasing availability in the UK, and we're certainly one of the countries that's quite lucky to have a good number of specialist residential group homes, has, I think, been very useful and very important, and in certain cases of my patients, life-saving. They're not for everyone, and there are lots of issues about trying to find placements, particularly that are close enough to family homes. and suitable placement when sometimes there can be other issues like behavioural issues or interpersonal difficulties that can make it difficult, let alone some of the funding issues and difficulties from each local area in achieving placement. But if you have an appropriate advocate, and I must say that PWSA are excellent in that regard, and must thank Patsy particularly with my patients for doing an excellent job in helping navigate the route into such residential placement. In terms of obesity management, it needs an early institution of a low-calorie balanced diet. But certainly when children are younger, of talking about the inevitability in the vast majority of patients, even when in the very young ages, children are not overweight yet, and sometimes even can be underweight, but talking about that inevitability. And I think there has been a real difference in the patients who have been diagnosed as children now to those that were diagnosed a lot earlier. And certainly many of my patients were adults, were sometimes even not diagnosed until very late. I had one person who was not diagnosed until their 30s. I just saw a patient this week who was diagnosed aged 18. And that's very different from now, when most diagnoses are made in the first few months of age. And that is important because when diagnoses are made very late, it becomes very difficult to construct an environment and sort of instill a behavioural management around eating to control the weight, and it becomes much more difficult. Whereas now I think the generation of children that are coming through into adulthood are very much healthier and with lower weight. They've also started growth hormone at a young age, by and large, which is benefiting their body composition and their exercise capacity. And so we have almost like a different generation of patients coming through. So hopefully things will be much improved. The restriction of access to food and money is not easy, and certainly in some patients that can be very difficult with a lot of behavioural issues. And there are obviously quite complex arguments around capacity around food and appreciation of the legal and ethical obligations. But our general view is that it is up to us, as those around patients with Prader-Willi, to provide a safe environment, and it's almost our obligation to do that, as there is certainly, because of the neurodevelopmental abnormalities in Prader-Willi syndrome, a impaired capacity to make decisions around food and balance the risk versus benefits of that. Exercise is very important, and certainly patients with PWS, if they go through a period where they're not exercising, can actually put on weight quite markedly. Growth hormone is certainly a benefit, as I said, in improving the body composition, so increasing muscle mass and reducing fat mass to a small degree, and it also helps with muscle strength and so and tiredness, enabling people to be more active, but it doesn't have any effect per se on the overeating. Unfortunately, even since 2008, we do not have any medications currently licensed for PWS for hyperphagia, but certainly the big change over the last 10 years has been the development of a lot of drug trials and a lot of interest from pharmaceutical companies to do trials. I'm sure Jennifer Miller will be talking more about that this afternoon. Here's a quick summary of where we are to date. Unfortunately, several of the trials that have been done have not been successful. Particularly, unfortunately, the Melendo study with levolatide, another trial of a drug that inhibited the production of ghrelin, the hunger hormone. Other drugs were effective, but unfortunately led to side effects. So rimonabant, which blocks the cannabinoid receptor, which led to side effects psychiatrically. Belurinib was very effective, a drug, but unfortunately led to increased clots and clots in the legs and clots on the lungs, and unfortunately 2 patients died of clots in the lungs, and so that had to be withdrawn. There were a number of trials ongoing, including the GLP-1, that's a gut hormone agonist run by Novo, that should be reporting very soon. Oxytocin, diazoxide, a trial that several of you may have been involved with, which has produced preliminary results, which, although not meeting the full target, do so show some suggestion of some effect to reduce appetite, and the open label extension study is still ongoing, and there's another trial of some brain acting drugs that is also showing some promise. So hopefully we'll see some more. Obviously, there are lots of consequences of the obesity. Diabetes obviously is one common. In my clinic, about 41% have diabetes and 10% have not true full diabetes, but slightly higher fasting glucose levels. Often I get contacted by physicians around the country to go, what's the best therapy? What should I use for the diabetes? Of course, often it is simply control of food intake that is needed. And I've had patients who've moved into residential homes, who I'll show you in a moment, who've been on lots of drugs, insulin, and they move into the residential home and suddenly their sugars crash and go really low, because obviously every time you eat, your sugar levels are going up. So really, control of the food intake goes hand in hand with managing the diabetes. We are quite lucky in the diabetes field of having lots and lots of drugs available now to treat diabetes. The mainstay is metformin, which improves insulin resistance, and that's a very good drug. It's weight neutral, or may even help people lose weight. These GLP-1 analogues that are being trialed for weight loss also have the benefit of increasing insulin secretion. They're unfortunately injectable, although there are some oral preparations that may be available soon, and actually preparations that can be just now given once a week. And they, in the general population, cause weight loss. We have to wait and see whether they cause weight loss in Prader-Willi syndrome. In my clinical experience, they don't, although I haven't gone up to the higher doses, and we wait to see the trial. These are drugs, SGLT2 inhibitors, that basically cause the kidney to pee out excess glucose to keep the glucose low. And because you're peeing out glucose, you're also peeing out calories. So they are supposed to be associated with some mild weight loss. Although that sounds great, in my experience, when I've used them in a few women with PWS, they do increase the risk of getting urinary tract infections, because basically there's more sugar in the urine, and also thrush, and so they haven't been particularly well tolerated. In men, it may be better. DPP-4 inhibitors, these are drugs that increase the amount of GLP-1 hormone in the body, and may be of benefit in controlling sugar, but their effect size is pretty small. They also don't seem to have the protective effects on the heart that some of these other drugs like the GLP-1 analogs do. Pioglitazone is a pretty old drug that basically makes the insulin more sensitive. It went out of favor many years ago because of concerns about weight gain and risks of heart failure. I do tend to use it quite a lot because I haven't found the weight gain issues to be a particular problem, and it's basically tackling the basic problem, which is insulin resistance, so I do tend to use that. I do try and avoid these drugs as much as possible. That's the things like gliclazide or insulin, for two reasons. One, they are often associated with weight gain, and there's also a risk of low blood sugars, and of course that promotes overeating because of the need to correct the low blood sugar and therefore weight gain. If you are needing insulin, certainly just the long-acting insulins rather than the short-acting insulins would be better. And I've managed to avoid insulin, certainly short-acting insulins in the majority of my patients. Thankfully, people with Prader-Willi syndrome don't seem to get as much high cholesterol levels as you might expect from their obesity, but certainly as they get older, and certainly above the age of 40, if their cholesterol levels are high, we will treat that. So when we look at our clinic in terms of the body weight, the real issue is how to manage that. And as I said, the residential placement is, to my mind, the most important thing to manage that. So we did a review to see how the body weight is different between the different types of placements. That's whether in the family home, supported living, so that's usually living on your own with 24-hour, usually carers. Residential homes with multiple residents, either a non-specialist or a specialist home. And when we look at it, either the first visit in my clinic or the last visit in my clinic, certainly the specialist residential homes seem to be much better, whereas the supported living and non-specialist residential homes don't do so well in terms of body mass index. Now, it is variable and depending on local circumstances and the particular individual, some may be still beneficial, but by and large, it looks like the special residential homes seem to be better. And when we look at the change, when people have moved from one to another, certainly there's a reduction in weight in the specialist residential homes, whereas going into supported living often is not that successful, often because unfortunately there's a high staff turnover or the staff are not so experienced. The non-specialist residential homes seem to be quite variable, maybe better sometimes than supported living, but the numbers here are small. There are increasingly number of specialist residential homes around the country by a number of providers. There is, however, a bit of a geographical problem in that we have none in the southwest. There's only one actually within London itself, in Hounslow, and so geographically we are rather separated, which can cause a problem. Just to give a few examples of case anecdotes. So these are anecdotes, so just to be aware of that. So this is someone who was in the family home, gaining loads and loads of weight, got into a specialist residential home, did tremendously well, weight came down. When they went to the specialist residential home, they were on 4 medicines for their diabetes, and this is their sugar control. Into the specialist residential home, came off insulin, and now is just on metformin, and their sugar control is normal. So, control of the food dramatically improved the diabetes. Another patient in the family home, not doing so well, specialist residential home, loses weight, had a period when they were injured their leg and wasn't able to exercise as much, led to weight gain, so very sensitive. Similarly, diabetes control markedly improved in the specialist residential home, insulin doses coming down, again, a period of impaired physical activity leading to some slight increase in the diabetes, so very sensitive to that. In the family home, weight gain into a non-specialist residential home, initially lost weight, but it wasn't maintained. Into supported living, initially lost some weight, then regained the weight. Unfortunately, we then were unable to get permission for a specialist residential home and had to battle quite a lot to try and get that. Unfortunately, that patient subsequently passed away before we were able to get a placement in a specialist residential home. Again, weight gain in a non-specialist residential home into the specialist residential home, much better weight control. One of the big problems we have, of course, is prevention, because, of course, this is treating obesity. Here's a patient who was in the family home, gradually weight gain, BMI not terrible, but gradually gaining weight. And unfortunately, funding for a specialist residential home has been refused because they're arguing that it isn't needed, the patient isn't particularly unwell. But of course, what is needed is to prevent this person gaining weight and gaining complications, and that's a lot of issue, and we struggle sometimes to get funding for that. There isn't much published about the benefits of these specialist residential homes, and we're trying to, in Europe, do some surveys of that, and through IPSWO as well, get some more data on that. A paper just published from the Dutch group in Rotterdam, looking at people in Prader-Willi home, non-Prader-Willi home, or family home, did show that the weight was lowest in the Prader-Willi home. We're a little bit cautious of this data because the people in the Prader-Willi home were younger than those in the non-Prader-Willi home. And also bear in mind that this group are actually very well controlled generally, with average BMIs, even in the non-Prader-Willi home of 30. The Netherlands has a great system whereby basically everyone in the Netherlands is looked after in a single centre in Rotterdam, both for children and adults, and so they're able to get much better control. And also there's more hypertension, which will go along with the higher body weight in the non-Prader-Willi home. So there's a suggestion that certainly the Prader-Willi homes may be better, but we need more data. Sex hormone replacement is commonly needed in men for both bone protection, improvement of muscle mass and strength, and reduction of cardiovascular disease. In the olden days, we used to use injections every few weeks, but that led to very high peaks. So now we tend to use these 12 weekly injections that are given at the GP surgery at lower doses than are usually needed in adults. And I think that's important to realise. And sometimes the gel, and certainly when we first start the therapy, the gels are quite good. This Tostran one can be given as a gradually increasing dose, which makes it quite easy to give. In women, the vast majority will either have no periods or irregular periods. Sex hormone replacement we give in the majority. The only reason we might not is particularly if they're very obese. We don't have to have periods, so we can use continuous estrogen and progesterone if periods are not wanted or intermittent. We try and use as low dose estrogen as possible, and particularly if they're overweight or have high blood pressure, we would tend to use patches or gels because they avoid the complications of increasing the risk of clots in the legs and lungs and increasing blood pressure. And a number of people have to switch over from one to the other. So growth hormone. So we're very well aware of its benefits in children in terms of improving final height, improving body composition, improving breathing ability, improving well-being. But in adults, we don't have as much data as we would really like. It seems to be safe generally, but we have to be very cautious in those that are particularly obese or have very poorly controlled diabetes, because it can increase the risk of obstructive sleep apnea, so blockage to the breathing or worsening of sugar. But we don't have a great deal of data in adults. So at the moment, growth hormone is not particularly licensed for adults with PWS. And so what I tend to do in my clinic, if I inherit someone from a pediatrician who's been on growth hormone, when they achieve final height, and they need to usually drop down to the lower dose that's used in adults. And then when I see them, I would usually stop growth hormone for at least a month and then retest with a stimulation test to see if they still have a low growth hormone. And in the various papers that have been published, not everyone still has a low growth hormone. It varies up to about 55%. If you don't have growth hormone deficiency, we cannot carry on giving growth hormone in adults. If you do, you can. If you are still low in growth hormone and you're under 25, under the NICE guidelines, we're allowed to give growth hormone replacement to achieve peak bone mass. So your peak bone mass is about the age of 25. But after 25, either in terms of continuing it or starting it, the reasons under NICE is for psychological benefit, improved quality of life. And there is a score called the AGDA questionnaire, and you need to be scoring over 10, and you need to decrease by 7 over at least 9 months to be able to continue it. The trouble is that this questionnaire is not validated in something like Prader-Willi syndrome, where there's other things contributing to impaired quality of life. It's also a very crude questionnaire of yes, no. But unfortunately, that is the guidelines we have to go by. The improvements in body composition that we know are certainly there with growth hormone in adults is not enough, according to NICE, to justify treating with growth hormone. But of course, that is what we try and use it for in particular. So it very much depends on whether this can be sneaked through sometimes in local situations. There is some evidence certainly of improved motor function and a little bit of evidence of cognition. There are actually questions in the literature, though, as to whether you actually need to fail one of these stimulation tests to show growth hormone deficiency to benefit. And in fact, there are some studies to say that even if you pass those tests, you may still benefit. The other problem we have is that basically growth hormone stimulates a hormone called IGF-1, insulin-like growth factor 1, from the liver and also other parts of the body. And often we see patients who pass their stimulation test but actually still have low IGF-1. And since we want to stimulate the growth hormone up, the IGF-1 into the normal range with the growth hormone, could we give growth hormone? But unfortunately, that isn't a reason why we're allowed to give growth hormone. And it may depend on whether people are overweight or not, whether they've had growth hormone in childhood, and obviously we need to make sure that they're replaced with other hormones before we can assess whether they might benefit from growth hormone. So we usually start growth hormone, but we sometimes need to stop it. Certainly if there is massive weight gain, we need to stop it, and we need to be cautious of that. And certainly the doses that we need in adulthood are less than in children. While people are on growth hormone, we need to monitor them regularly, which will be part of our normal assessments of blood pressure, monitoring the dose to get the IGF-1 in the upper half of the normal range, watching for sugar problems. There is a risk when starting growth hormone of the thyroid becoming underactive, so we must always monitor that. We monitor bone density, but it isn't quite clear how often. We should monitor quality of life, but what is the best assessment tool for that? We don't routinely measure sort of physical performance, but maybe we should be. We don't necessarily, as is usually the case in children, do regular sleep studies in adults on growth hormone replacement. But maybe we should be, but certainly if there is concern about obstructive sleep apnea with excessive daytime sleepiness or snoring and things like that, we certainly should be doing them at baseline, if not as follow-up. In my clinic, about half of the adults are on growth hormone replacement. The reasons why the other half wouldn't be are either because they don't want it, or they don't want daily injections, or because they passed the dynamic test, or because unfortunately their weight is too high to allow it. And about half of my patients have had growth hormone in childhood. That would be very much different from the generation coming through now. And I think it's important to say that these AGDA questionnaires, there is a huge range of that, so from 4 to 23 out of 25. And this is part of the problem because we're only allowed to have growth hormone over 25 if you have a score before you have the growth hormone, after stopping the growth hormone, of above 10. And that isn't necessarily very reliable in someone with PWS. So certainly in adults, growth hormone therapy improves body composition. It may decrease the body fat without actually changing the weight, and that's important to realize. It may lead to some deterioration in the sugar control, but that's usually hopefully transient. The trouble is we don't have a lot of studies. There's not a lot of studies looking at these various factors, and often they've looked at subgroups, and so there aren't a lot of numbers. And the other problem is, do we need to look at how growth hormone deficient they are at baseline? And we really need many more trials. And we certainly don't have any real long-term data to know whether growth hormone therapy improves the risk of heart disease over time, which we know it does in non-Prader-Willi people with Prader-Willi syndrome, and the benefits of that. Just to give you an example of some raw numbers, and this is possibly a better example of seeing the benefits of growth hormone. This is when you stop it. So when a child reaches final height and you stop the growth hormone, what happens versus continuing it. And you see that over the subsequent 2 years, the people who stay on the growth hormone have about 3 kilograms less fat and about 1.5 kilograms more muscle. So that isn't huge amounts, but obviously every bit helps. And again, another study looking at in adults the effect on motor function. The growth hormone increases the amount of muscle in the limbs on CT scans. There's less fat in the muscle, and it improves how much time they can do on the treadmill. But look at these effect sizes. Basically, it's about an extra 1.5 minutes on a treadmill. And the question is that a biologically important amount? So moving on to other hormone problems, underactive thyroid is seen not that commonly. Some studies have shown high prevalences in infants, but in adults it's much less, and it may be something like 10 to 25% of patients who have an underactive thyroid. And as I said, you need to be careful when you start the growth hormone because you can develop an underactive thyroid when you start the growth hormone, and it's important to monitor that. There was a lot of concern many years ago about problems with steroid deficiency, cortisol deficiency in PWS, and everyone was getting very concerned and maybe giving steroid cover for operations and things. Really, that doesn't now seem to be a problem. And we just published from several European centres the largest study in adults, and only 1.2% of patients had a low cortisol level based on the sort of gold standard tests. And all of us looked through our medical notes of 650 patients, 200 of whom have had surgery without steroid cover, and none of them had problems. There was concerns that people might have steroid crises because they had a low steroid, because normally a response to surgery would be to produce more cortisol. But that does not seem to be a clinical problem. So I think we're all very much more relaxed about the risks of that. I do have one patient of mine who does have it, but it seems to be very rare. Thin bones are a problem, seen in about 20% of my patients, and slightly thin bones in about a third. The scoliosis that happens in childhood does not seem to be a particular problem in adults, although obviously if severe can put some strains on the lungs, but by and large we don't tend to see those sort of patients very often now. Vitamin D deficiency is very common in Prader-Willi syndrome, as it is actually in the general population. It's exacerbated by people with PWS because they're generally overweight and vitamin D deficiency is low, and they're possibly not getting out as much as they should, particularly in the winter months. And so it is now actually government recommendations that everybody in this country gets vitamin D supplements over the winter months. Usually the dose are about 400 units. That tends to not be enough in my mind, and so generally I keep pretty well all my patients with PWS 1,000 units a day pretty well all year round. If you're having a normal dietary dairy intake, you shouldn't usually need calcium supplements. You may need more in the winter because we get most of our vitamin D from sunlight, or if you're obese, and so we may need to go to the sort of high dose prescribable vitamin D. This you can just get from the chemist or health food shop. You may need higher dose that you can take maybe every 1 to 2 weeks as necessary. this is this nice review that came out of the group in Rotterdam looking at adults with PWS, and they were just commenting on how you need to often actively look for these problems, and certainly if you're not in a specialist PWS clinic that may be looking at these things, a lot of these things may be missed. So in white is the percentage of patients that have these patients missed. Amazingly, 43% have not been diagnosed with low sex hormones, 40% have not been diagnosed with vitamin D deficiency, and even hypertension and underactive thyroid and diabetes is being picked up. So it's important that those are screened for. The other big problem is sleep problems related particularly to obstructive sleep apnea. Occasionally there is an impaired drive to breathe, although that tends to be mainly a problem in infants and young children. And then occasionally we see patients who have obesity-related difficulties in taking a breath, and also sometimes just the fat around the chest can impair breathing, leading to impaired ventilation. And this puts a strain on the heart, can lead to high blood pressure in the lungs, and strain on the right side of the heart, leading to heart failure. It can increase the risk of clots in the lungs, and it can increase the risk of complications when people get chest infections, viral chest infections, and a risk of respiratory failure. And unfortunately, this is a common cause of death in people with Prader-Willi if they are extremely obese. And there are a number of contributions to this related to the obesity, abnormalities in the brain, in the parts of the brain involved in breathing control that are less sensitive to changes in the oxygen and carbon dioxide in the blood. The floppiness, although that's less of an issue in adults, although it can be to a certain extent with the growth hormone deficiency. Obviously in children, problems with adenoids and tonsils, although those will usually have been removed if that was an issue by the time they're an adult. And although this is a rather complicated slide, what it means is, in the end, all the problems about PWS, the behavior, the hormone problems leading to overeating, the metabolic complications, which may impair the function of the heart because of problems to the blood vessel supply in the heart, diabetes, high cholesterol, high blood pressure, the low muscle mass, scoliosis, leg swelling, leading to high fat, low muscle, leading to obstructive sleep apnea, risk of clots, risk of what we call this high blood pressure in the lungs, pulmonary hypertension, increasing the risk of heart and lung disease in PWS. And certainly I'm now doing very regular heart scans, echocardiograms in my patients to look for problems. And that's obviously a common cause of death. Unfortunately, there are other unusual causes of death in Prader-Willi syndrome, things we need to be watching out for. This is from a survey in the USA at the Prader-Willi Syndrome Association of unusual causes, one being either spontaneous or rapid food ingestion related gastric rupture and necrosis, which can happen. And anybody with PWS who presents with abdominal pain or vomiting or increasing bloating needs to have problems with the bowel ruled out. And I've certainly had at least one patient who spontaneously had a small bowel perforation, not the stomach, but the small bowel, just out of the blue. And obviously another complication, particularly when you're eating large amounts of food quickly, is the risk of choking, and these can cause problems that need to be watched out for. Bowel problems, we're increasingly recognised are a problem in PWS. There is general gut dysmotility, so the bowel doesn't work properly, so there's a tendency to constipation and abdominal bloating. I find that probiotics are very helpful for managing these symptoms. That's good bacteria. This one, Biocult, 2 capsules a day, I usually recommend. Laxatives are sometimes needed. Lactulose is not advisable because it basically leads to bacterial overgrowth because it's really a fuel for the bacteria. And the other things we tend to use are Movicol and Dulcolax as stimulant laxatives. And involving a specialist gastroenterologist is often needed to help with advice about these sort of problems. And this is this gastric necrosis that does seem to happen very rarely. It may be related to impaired emptying of the stomach that is seen in some patients with PWS. And part of the problem is why it may not be seen or dealt with is because of the reduced symptoms. There's less vomiting, the high pain threshold may mean that people don't present with it. And lastly, I just wanted to finish off to bring things up to date. I thought it's worthwhile mentioning COVID-19, which is all the reason why we're all doing this by video. I thought I'd just review that briefly as is relevant to PWS. It should be fair to say at the moment we don't actually have any data about whether people with PWS are at increased risk of either getting it or having complications of it. Tony Holland has developed a survey that's ongoing through the International Prader-Willi Syndrome Association to try and collect some data, and certainly if any of your children or clients develop COVID-19, it would be grateful if you could go to this website and record and ask some questions about symptoms and things. We do certainly know that obesity and type 2 diabetes increase the risk of severe illness and death with COVID-19. Interestingly, Down syndrome has now been added to the list of those who are extremely vulnerable. And in a recent survey, very high risk, 5 times the risk of hospitalization and 10 times the risk of death, compared to, it must be said, other learning disabilities which were only minimally raised, 1.3, so 30% increased risk. And there may be some things that are peculiar to Down syndrome, maybe affecting the immune system. They do have increased risk of heart problems as well. So that doesn't necessarily at all translate to Prader-Willi syndrome. So when we look at what is known about the risks for COVID-19 illness that may be applicable to Prader-Willi syndrome, where are they? Certainly in what the names have changed, but it's the vulnerable group or the moderate risk group for those with a BMI above 40, those with diabetes, sort of asthma, heart failure, kidney or liver disease, and I've added probably mild obstructive sleep apnea. That isn't specifically mentioned in the government guidelines, but I would probably add that. So that is a moderate increased risk, whereas those with severe respiratory conditions, and that's really the only category in the extremely vulnerable that would be added. I mean, unless you have something like cancer or an immunosuppressant therapy, and that would include severe asthma or, to my mind, obstructive sleep apnea on ventilation at night, CPAP or something like that. And there are lots of reasons why obesity increases the risk in terms of affecting lung function, the function of the heart and kidneys, and the risk of diabetes. Of course, there may be concerns about delayed diagnosis in Prader-Willi syndrome because they may not develop a fever and they may have a high pain threshold and may not present with symptoms. Obviously, the treatment that we've all got in terms of, so the preventative treatment that we've got in terms of social distancing and lockdown has its issues in people with PWS. There may be difficulty wearing masks, increased stress and anxiety, particularly around the change of routine. That might also lead to some emotional overeating. Obviously, there's going to be a loss of visitors. A big problem, of course, reduced physical activity, not going out as much, closure of the day centres and sporting facilities. And certainly many of my patients have actually returned to the family home from residential facilities. In fact, I have to say, in the vast majority of cases, many of my patients have tolerated very well with all the restrictions. And actually, several of them have done really well in terms of losing weight within the family home, especially if they were in non-specialist homes to start with. And so really, it's just a question of maintaining as much as possible. I think I prefer the term physical distancing as opposed to social distancing, the hand washing and the mask. I think maintaining physical activity is really important and trying to get out and doing regular walking. I think it's important to make sure that everyone with PWS gets a flu vaccine because obviously we're entering flu season and the combination of the two may be important. There's been lots on social media about potentially the protective benefits of vitamin D in preventing COVID-19 and whether low vitamin D may be one of the reasons why people of certain ethnicities may be more at risk. There is, it must be said, no good evidence for that at the moment, but certainly, for other reasons, vitamin D replacement is important in PWS, and I think this is, if it does have some protective reason, will be another reason to continue with it. I do, however, think it's important to put the risks of being overweight in context, and although there is an increased relative risk if you are overweight or have diabetes, it's still a relative risk, not an absolute risk. So although if your BMI is even over 25, there's a 4 times the risk of death and a 7 times the risk of advanced respiratory support. That means, onto breathing machines or breathing support. If you have diabetes, certainly the worse your diabetes, you increase the risk. If your BMI is high, you increase the risk, but it's much less than the risks. So we're talking maybe a 20 to 60% increased risk. Maybe if your diabetes is poorly controlled, 60% increased risk. But compare that to being over the age of 80, which is a 4.5 times risk. And this is still relative risk, not absolute risk. And it is proportionate to your weight. So this is the risk from a Chinese group. of hospitalized patients with BMI, your risk of having a severe illness are increased. But let's not get it out of proportion. The absolute risk is still relatively low, and it's certainly a lot less than being elderly and not similar to being male, actually. The other thing, of course, with adults in PWS is now our populations are getting older. We don't have a lot of data about aging in PWS. We recently published some data to show that when we look at brain scans, the brains of people with PWS are actually older than you might expect from their actual age. And this may be a reflection of either the gene abnormalities in PWS. It doesn't seem to be related to the obesity, however. It may be something different. And we don't know if there is an increased risk of aging or increased risk of cognitive decline in PWS as patients get older. So just to wrap up, early diagnosis and multidisciplinary management has really changed the disorder, and so the patients coming through from child into adult are very different. Our mainstay of management of obesity is control of food, and the residential placements are life-saving here in many cases. The work that PWSA does is also very important in that. Physical activity is very important. There are benefits of growth hormone, but the magnitude of those remains unclear, and they're not huge. There are other hormone deficits that we need to replace, but the concerns about steroid hormones seem much less worrying. Sleep disorder, breathing and heart problems and lung problems are what we need to prevent, because those are often, unfortunately, the cause of death in those, particularly who are very obese. It is a multi-system disorder, and we need to think about all the different body systems that are involved, whether that's the gut, the lungs, and things like that. I've gone over the COVID-19, which we do now have a lot of drug companies interested, and there are several clinical trials ongoing, so hopefully we may have some drugs soon that I'm sure Jennifer Miller will talk about this afternoon. And we have to wait and see whether aging brings any differences in PWS as our population gets older. Thank you.
Tony, thank you so much. Are you able to hear me okay?
Yep.
Excellent. We just like to double check just to make sure that that you can hear us. We've had some issues at our end. It is going to look like I'm looking at a different camera, but I can see you. It's just so that I've got the screen with the questions on as well. Thank you very much for your time and for joining us today. As always, that was a really, really interesting presentation. Really glad you mentioned about aging and stuff as well, because we've had a few questions through regarding that. So that's brilliant. We do have a number of questions for you. I'm going to get through as many as I possibly can. Those that we can't answer, would you be happy for me to forward them to you by email?
Yep, that's fine.
Perfect. Thank you very much. So the first question that we've got is, how do we find a suitable multidisciplinary centre? I will go full in.
Move to an area that has one. It's difficult. I mean, just from a personal point of view, unfortunately, PWS is not my whole job. I have had to restrict the patients that I can see because otherwise I'd be overloaded. It is difficult, and I don't think I have an answer to how we can improve the interest and experience of adults. I'm talking about adults here in the UK. I don't know how we do that. Whether we can do hub and spoke models. Whether actually what COVID has introduced us, and I mean, now I'm doing all my clinics remotely, it may be that remote clinics in the future offer some possible way of solving this.
Really good point.
Do some things remotely, and that maybe that will be a solution. And of course, we need to somehow get people interested in PWS. And although in the pediatric community that's been really successful, I must admit, the adults, there are not many adult endocrinologists interested. I think the drug trials may also change that, because actually now we've had several centres taking part in the trials, and certainly I think if we get a drug available, that will change things as well. So I don't have an easy answer, I'm afraid. All I can do is, obviously, if you do have a local endocrinologist, is they can always reach out to people. I mean, I don't want to get loads of emails because otherwise I'll be swamped, but I do not respond to questions and do advice. I did a chat with a psychiatrist in a inpatient unit just this week to offer advice. So there are a number of us around, and so certainly we can do that, and that may be a model that could help.
Okay, fantastic. Thank you for trying to answer. I knew it was going to be a difficult one. One of the things that we often do as an association as well is to ask parents that if your adult sees an endocrinologist, to ask them if they would be interested and to reach out to us, regarding running a PWS clinic. And you have been incredibly helpful to us over the years when it comes to people needing advice. Just to let you know, we've had some really beautiful comments from people saying, thank you, Tony. We'd like to personally thank you for your help over the years. Great presentation. Many thanks. Really informative talk. Very informative. Absolutely brilliant. Excellent. So it's really nice, I think, as well, to pass those on as well as the questions.
The one thing we miss out on when it's remotely, we can't see the audience smiling.
Absolutely, you can't see the reaction to what people are saying and how people are taking the information. So we've got another quick question for parents with younger children. Would you advise them to start saving or planning or researching for a specialist supported residential home, as soon as possible?
Well, I don't think they need to save. But specialist residential homes should be paid for out of usually a combination of an NHS continuing healthcare budget and a social care budget. And there's debates about whether, what proportion. Money should not be a factor. Unfortunately, the local authority and the local clinical commissioning group may have financial reasons why they refuse it, but you shouldn't be having to pay for it. I think realizing that this may be appropriate is a thing to be thinking about early. And I think that I'm not saying inevitability, but I think that benefit of it in terms of not just in terms of weight management, but in terms of socialization and activity, is something that sometimes is difficult for families and parents to come to terms with, because it involves quite a major change. And I think what I often find when patients come and I see them as an adult for the first time, I actually introduce it usually just in passing at the very first clinic, because it often takes quite a while to be thinking about. So I don't think there's any harm in thinking about that possibility earlier. What I think may prove to be difficult, however, is A, the number of places, and B, getting the reality of getting funding when, as the last case history I gave, when people are actually under very good weight control, because actually I think it may be difficult to get the funding for that in the current climate, unfortunately. And who knows whether, given COVID and what that's doing to the national economy, it may be even more difficult. So I don't think it's harmful to think about it as early as possible, and look online. It doesn't have to happen overnight. It's a slow process, and getting everyone on board and involving PWSA, who are very good at helping you manage that. I can't emphasize how important that is, and that's been fantastically helpful in doing that, just even in the last few weeks.
Thank you very much. So just a couple more questions. There's one that's quite general. Do you know if growth hormone for adults is more commonly prescribed in other countries, such as the USA, France, Netherlands?
So it varies from country to country.
Okay.
Every country has its different rules. I mean, Australia didn't have it at all for many years. Canada, it's proven very difficult. In adults, I think in France it's more, and I don't know what the rules are as to do it. And certainly in the States, it's probably more. In Netherlands, it's very widely used in adults. They probably have the best data, and Scandinavia reasonably often. So it does vary from country to country. It
varies from country to country. There's a really interesting question. It may be that you already answered this, but someone's asked how final height is determined with regards to stopping the growth hormone.
It's basically when you stop growing. So
is it just literally by a measurement of height?
Yes, it's measured. So you look at the rate of change of height over time, so meters per year, and basically when you stop growing.
Right, okay, perfect. Thank you very much. That was a nice, easy one. Another question, should a 19-year-old female with PWS commence sex hormones to induce periods? And you may have already answered it.
Yeah, well, I think it depends. So it's a question of seeing what their estrogen level is.
Okay.
So if your estrogen level is low, you're at risk of getting thin bones. It also may impair your heart health as well. And so one would be looking at increasing it. So if your estrogen level is low, we want to give sex hormone replacements in some form. As I said, it doesn't have to lead to periods. Occasionally we see people who have reasonably good estrogen levels, but they don't actually have the periods.
Okay.
What you might be able to do then is just give progesterone
Mm-hmm.
intermittently to induce a period. So basically estrogen causes the lining of the womb to increase, and then when you give progesterone, that causes the lining of the womb to come away, and that's what causes the bleeding and a period. So if your estrogen levels are reasonably high and you have quite a thick lining to the womb, there is a risk over time of an increased risk of womb cancer if you don't induce a period. So that's why there is an adequate estrogen level, but they're not having periods, mainly because maybe the pulsatility. So basically the hormones are pulsatile, and that's why you get the periods. So if that pulsatility is impaired, then you may give just intermittent progesterone just to cause a bleed every once in a while. It doesn't have to be once a month, it could be every 2 months.
Okay.
And that is occasion. I think there were a couple of patients who I've managed with just intermittent progesterone, but by and large, people will tend to have low estrogen levels and need estrogen replacement. So it'd be important to measure the estrogen levels in that person, and also to get a bone density scan would also be useful as a baseline.
Excellent, thank you very much. Regarding surgery for scoliosis and growth hormone, if someone of about the age of 15 has had surgery, for scoliosis, should the GH continue if they've been on it from a very young age, or are the two unrelated?
So there's no evidence that growth hormone therapy itself makes scoliosis worse.
Okay.
It is growth, natural growth. That's a period where scoliosis may get worse. But if it's very severe, sometimes growth hormone is stopped. Restarting it needs to be a discussion with the pediatric endocrinologist and the orthopedic surgeon. But certainly if there has been surgery and things are nicely fixed, that would suggest that probably growth hormone can restart. But that would need to be a discussion with the local endocrinologist.
Fantastic, thank you very much.
It wouldn't prevent me giving it as an adult.
Okay, brilliant. We've got time for one more question. What blood tests are needed for young adults who are on growth hormone therapy? And they've also said many thanks for your really informative talk. I seem to have lost the ability to talk. I'm very sorry.
So blood tests on growth hormone. So you need an IGF-1, so that's insulin growth factor 1, 2, because that's what we use to assess the growth hormone dose. And there's a range of IGF-1 depending on your age, and we want the IGF-1 to be not high, but in the upper half of the age range, maybe even in the upper third.
Okay.
Monitoring for diabetes, so that might be a glucose. Doesn't have to be a fasting glucose, although if you can, that's nice. But a better screen is what we call the HbA1c, that's the glycated hemoglobin. So that gives an idea of the average sugar over about 3 months. You need at least yearly your thyroid function test done. That's needed whether you're on growth hormone or not. But occasionally growth hormone therapy can lead to the thyroid hormones being low. You need watching your liver function test just to make sure that you're not getting fatty liver, and you would do your kidney measurements on that as well. And vitamin D levels, just making sure that they're okay to help with bone strength.
Excellent. Tony, thank you so much. As always, you're incredibly informative. And as you say, it's really different and unusual to do it this way because you can't see the way that people are reacting to you, but I can. And we've got comments like a very rich presentation and talk. Thank you very much. Really brilliant talking, very clear. Thank you, Tony, for your really helpful information. So it's nice to be able, like I say, to pass on the lovely comments to you as well. I will be emailing some questions over to you because we've had quite a few. And thank you very, very much for your time, and thank you very much for joining us. It's been absolutely amazing.